So look, when you look at ascites, the first thing to do is to check SAG, and you'll have two camps essentially. You'll have, you'll have the one where it is low, and low means it's less or equal to 1.1 gram per deciliter. Oh, deciliter actually. Did I put liter in here? Idiot. And less than 1.1 gram per deciliter, that would be non-portal hypertension related, as in our case. Therefore, you want a situation where it is a likely exudate. And likely exudate, you're gonna want things like inflammation to be responsible for the ascites, maybe from an infection, maybe you'll want malignancy causing an inflammatory response. So you think of things like tuberculosis because of its biliary spread, infections in general. It doesn't have to be, of course, a viral infection. You could have abscesses in the liver. Give me a reason to develop an abscess in the liver. What are you thinking with anchovy paste look? Requiring exactly, Sharon, maybe an amoeba. Why not now with an acute inflammation? Look, it doesn't have to be the liver itself. It could be close to the liver, pancreatitis. And can damage your liver. Serositis. Peritonitis, in other words. So something with inflammation or malignancy would go very well. Whereas if you have a SAG that is greater than 1.1 gram per deciliter, then this is classically portal hypertension related. And I gave you the main culprit, the likely transudate because of hydrostatic pressure being increased, is primarily issues with cirrhosis. So now that's going to be literally more than 80% of your cases. And 2/3 of cirrhosis is going to be itself associated with alcohol, but that's where you're going to see congestive heart failure patients, right-sided heart failure in particular, people with that Budd-Chiari syndrome. Can you give me a reason to develop Budd-Chiari? Aha, so in a nephrotic syndrome, would you have a transudate or an exudate? You're losing your albumin in the blood. What do you think? You have less albumin in the blood, therefore you decrease the gradient. Is that okay? So Sam, that would lower the SAG. That would be a nice one to put in there. But the generalized edema of nephrosis is not necessarily with ascites, but if you had ascites as a result. So is it an exudate in that situation? Well, in that situation, your issue is you've lost oncotic pressure. So there's more osmoles, if you want, outside dragging water. So that's still a transudate. So that's why I put likely exudate, because it doesn't have to be. A nephrotic syndrome, for example, could have a low SAG and have a transudate in that setting. But then it's not an issue with hydrostatic pressure. So that's why, but well thought there. Budd-Chiari, we put portal vein thrombosis, idiopathic portal fibrosis, we put. So see question above. Meanwhile, besides this, in the original question I gave you, Well, you saw that we had various lab tests for liver function and biliary function. So that's what we're going to put next, which are liver function tests. And when you look at liver function test, you did much better with this one with alkaline phosphatase, you remember? There's really three big types of liver function test. The ones that check hepatocyte integrity are always important. And to check out hepatocyte integrity is to look at an increased cytosolic enzymes in the serum of the patient. So showing you that you've destroyed the hepatocyte. Well, you know, this is where we measure such things as AST, ALT, and even potentially LDH. And those are classic for hepatocyte integrity. The other extreme, still linked to the liver, is to check the hepatocyte synthetic function, so that not only you look at the physical integrity of the plasma membrane by finding cytosolic enzyme in the serum, you know there's been some irreversible cellular damage, you can also look at the biochemistry of the hepatocyte. I'll make a question with the biochem in a second, and that's where generally in the liver function test we'll look at three different things. The serum albumin, and serum albumin, well, is going to be decreased, just like in nephrotic syndrome, by the way, Sam. So, but they're decreased synthesis. We look at clotting factors. Virtually all clotting factors are being made by hepatocyte. So I should see decreased clotting factors, or more specifically, increase prothrombin time, increase partial thromboplastin time. So PT and PTT are increased at the same time. And then the other big synthetic function is the detoxification of ammonia with urea cycle. And urea cycle is going to be decreased in its activity too. And that'll result in two classic findings here. The fact that you'll see low blood urea nitrogen, and the fact that you'll see increased levels of ammonia and glutamine, and glutamine being a way to try and carry ammonia in the periphery without having as much toxicity. The third aspect of liver function test is to check out biliary excretion. And biliary excretion function, there's two broad type of data to find, well, plasma membrane enzymes and to find them elevated in the blood. So plasma membrane enzymes to check for damage. And when you look at those, that's where you really have two big enzymes for biliary. You have the alkaline phosphatase, and what is the other one? To check for integrity of the biliary tract, tell me, besides alkaline phosphatase. Obviously, it's not AST, ALT, or LDH, that's for hepatocyte. Exactly. NAGHR, ALA, GGT. So gamma glutamyl transferase. Perfect. And these will be elevated, of course, in the serum. The other is to look for substances that are normally excreted through the bile. And now the increase in blood and in urine of the patient. And certainly for the blood, well, that's where we're going to measure, again, two things right there. And one is going to be serum bilirubin, and the other one is going to be serum bile acids. Now don't confuse the two. Bilirubin, a heme degradation product, and bile acids, as you know, these are some product derived from cholesterol and the bile salts to help fat absorption. For the serum bilirubin, don't forget that we'll look at total, direct, and then we calculate indirect. You okay with the main liver function test? Yeah? And what they allow us to see?